My name is Dr. Brian Quinn, and I have worked as a pathologist at Baptist Health since 1995. I am board certified in anatomic pathology, clinical pathology, and transfusion medicine, and a medical director of the blood bank at Baptist Little Rock. I am also actively involved in a blood management project here at Baptist. Earlier this year, Baptist Health Physician Partners established a multidisciplinary committee to oversee a system-wide blood utilization quality project, and we hope that this project will contribute to improved care and better outcomes for the patients that we serve. As part of this project, I have put together a series of presentations that are intended to update clinicians regarding the benefits of a conservative approach to blood transfusion. This presentation, which lasts approximately 25 minutes, will discuss Baptist Health's red cell transfusion guidelines, which have been reviewed and approved by the Baptist Quality Review Committees. The implementation of evidence-based transfusion guidelines is one of the pillars of a successful blood management program because these help to reduce variation in clinical practice. These guidelines were developed after reviewing the recent literature and are based upon practice parameters that have been published by multiple physician expert panels. The guidelines are intended to ensure that the most appropriate, efficient, and safe use of the blood supply is achieved, but they are not intended to override physician judgment. As medical professionals, we know that the benefit or therapeutic goal of a red cell transfusion is to improve oxygen delivery according to the physiologic need of the recipient. Thus, red cell transfusions are utilized for patients with a symptomatic deficiency of oxygen carrying capacity and for patients experiencing clinically significant tissue hypoxia due to inadequate circulating red cell mass. The decision to transfuse red cells must be based upon a clinical assessment of the patient that weighs the risks associated with the transfusion against the risks of anemia and what the anticipated benefit of the transfusion is. Many of the guidelines reflect the fact that physicians frequently use hemoglobin levels to help them determine when to transfuse, because this represents an objective criterion that is readily available in most patients. However, in addition to the hemoglobin concentration, a number of other clinical factors must be considered, including risk factors for inadequate tissue oxygenation, such as high-risk cardiovascular comorbid conditions, indications of organ ischemia, vital signs, presence or absence of anemia, rate of onset of the anemia, and the rate and magnitude of bleeding when present. Thus, transfusion decisions must be based not only on the patient's hemoglobin level, but also upon the clinical assessment of the patient. Optimal therapy should involve transfusing enough red cells to maximize clinical outcomes while avoiding unnecessary transfusions that expose patients to both infectious and non-infectious risks, and also increase costs. Because there is no reason to transfuse red cells unless doing so improves outcomes, a liberal transfusion strategy that utilizes a higher hemoglobin transfusion trigger would be preferable only if evidence supports its superiority over a conservative approach that uses a lower hemoglobin transfusion trigger. Thus, a restrictive transfusion approach is preferable if reliable evidence demonstrates either non-inferiority or superiority compared to a liberal approach. As more studies addressing red cell transfusion become available, it is becoming increasingly clear that liberal transfusion strategies are not usually associated with superior outcomes and instead often expose patients to unnecessary risks, and that a more conservative approach to red cell transfusion is typically associated with improved patient outcomes. Some of the relevant scientific evidence has been discussed in the other presentations that have been recorded. With regard to hemoglobin values, there is general agreement that red cell transfusion is only very rarely indicated for hemoglobin greater than 10, and that transfusion is likely to be indicated when the hemoglobin level is less than 7. The determination of whether hemoglobin concentrations between 7 and 10 justify or require transfusion should be based upon ongoing indications of organ ischemia. the rate and magnitude of bleeding when present, the presence or absence of symptoms, the patient's intravascular volume status, and the patient's risk factors for inadequate oxygenation, such as cardiovascular comorbid conditions. So again, the risk-benefit ratio comes into play. As I mentioned earlier, the Baptist Health Red Cell Transfusion Guidelines represent a compilation of practice parameters that have been published in the recent peer-reviewed literature by multiple nationally recognized physician expert panels, such as the American College of Critical Care Medicine, the Society of Thoracic Surgeons, the Society of Cardiovascular Anesthesiologists, the British Committee of Hematology, the National Comprehensive Cancer Network, the American Association of Blood Banks, and the American Red Cross. In this presentation, I'm going to highlight the guidelines that address the patient populations with anemia that are most commonly encountered in clinical practice and may require red cell transfusion. The complete guidelines, including the references, can be accessed by going to PhysicianNet and hovering over the Systems section under the Policies and Bylaws section and clicking on the clinical icon. In addition, a hyperlink to the guidelines has been placed in the EPIC General Blood Administration Order Set within the red blood cell section. The introductory note to the guideline emphasizes that they are not intended to be a substitute for clinical judgment and that the goal of the guidelines is to assist physicians when making transfusion decisions. However, the guidelines should not be considered as an absolute mandate to transfuse or not to transfuse. So again, it is emphasized that the ultimate decision whether or not to transfuse blood rests with the responsible physician in light of the individual patient's circumstances present. The general recommendation is that in the absence of acute hemorrhage, red blood cell transfusion should generally be given as single units, followed by reevaluation of the patient's clinical status, which is also referred to as the transfuse and reassess strategy. This single unit transfusion approach has been endorsed by a number of physician expert panels assembled by organizations such as the American Red Cross, the American College of Critical Care Medicine, and the Eastern Association for Surgery and Trauma, as well as multiple large hospital systems such as Stanford and the University of Michigan. In stable, non-bleeding, and non-hemolyzing adults transfused with compatible red cells, the hemoglobin equilibrates in approximately 15 minutes after red cell transfusion, and the transfusion of a single unit in an average-sized individual should increase the hemoglobin by approximately 1 gram per deciliter and the hematocrit by approximately 3%. Although most physicians have become comfortable with patients having hemoglobin levels in the 8 range without transfusion, many physicians get anxious when the hemoglobin falls below 8 and approaches 7 and worry that something harmful might occur without transfusion. However, studies have shown that most patients can safely tolerate hemoglobins in the low 7 range. This first practice parameter refers to asymptomatic hemodynamically stable medical patients without high-risk cardiovascular comorbid conditions. Based on evidence from multiple randomized controlled trials, there is reasonable consensus that this patient population can tolerate hemoglobin levels down to approximately 7 without transfusion. Results from several of these trials have been summarized in a separate recorded presentation in which scientific evidence evaluated hemoglobin thresholds for red cell transfusions was discussed. When the patient has cardiovascular comorbid conditions, transfusion practice parameters are somewhat more complex, and a higher hemoglobin threshold is generally recommended. Anemic patients with cardiovascular disease are a challenging group to discuss when it comes to red cell transfusion practice parameters because there are varying degrees of cardiovascular disease severity ranging from stable or chronic coronary artery disease to acute coronary syndromes such as acute myocardial infarction and unstable angina, and the published practice parameters vary somewhat with respect to hemoglobin transfusion triggers. Practice parameter number 2 refers to asymptomatic patients with chronic stable coronary artery disease, whereas patients with an acute coronary syndrome are addressed in a separate guideline listed here as number 3. I also want to mention that the numbering of these guidelines that I'm using in this presentation don't exactly match the numerical order of the guidelines that are published on PhysicianNet. So for patients with stable coronary artery disease, an 8 hemoglobin transfusion trigger is recommended. However, the optimal red blood cell transfusion hemoglobin trigger in the setting of an acute coronary syndrome has not been established because there are no high-quality studies that can be used to formulate recommendations regarding the hemoglobin threshold for red cell transfusion in this patient population. This lack of consensus is illustrated by practice guidelines that have been published by 2 U.S. physician panels. A red cell transfusion clinical practice guideline published by the American Association of Blood Banks in 2012 suggested adhering to a restrictive strategy in patients with pre-existing stable cardiovascular disease and considering transfusion for patients with a hemoglobin level less than or equal to 8 or for symptoms, which is the same as Baptist guideline number 2. However, citing the lack of prospective randomized data, the panel chose to not make a recommendation one way or the other regarding a liberal transfusion practice, which would call for transfusion when the hemoglobin fell to below 10, versus a restrictive transfusion practice, which would call for a transfusion only when the hemoglobin level fell below 8 in hemodynamically stable asymptomatic patients with an acute coronary syndrome. On the other hand, in a more recent review, the American College of Physicians published a so-called weak recommendation for using a restrictive red cell transfusion strategy in patients with heart disease using a hemoglobin trigger of 7 to 8. But in their recommendation, the authors did not stratify the recommendation based on the presence or absence of an acute coronary syndrome. As a result, the current Baptist recommendations for patients with cardiovascular comorbidities are divided into 2 guidelines. The first addresses patients with stable cardiovascular risk factors, stating that transfusion should be considered when the hemoglobin is 8 or less. The second addresses patients with an acute coronary syndrome, such as unstable angina or an acute myocardial infarction. Because of a lack of pertinent data from randomized controlled trials, the guideline for anemic patients with an acute coronary syndrome lists a relatively broad hemoglobin range of between 8 and 10, which may be considered as a threshold for transfusion, and this guideline also includes a note as listed on the next slide. The note states that some observational and retrospective studies have suggested lower short-term mortality in elderly patients with an acute myocardial infarction when transfused with a hemoglobin level as high as 10. However, the note goes on to state that there are a lack of clinical data from randomized controlled trials that address the appropriate hemoglobin transfusion threshold for patients with acute coronary syndromes. The note then continues on, referring to a meta-analysis of retrospective studies involving patients with acute coronary syndrome that actually demonstrated that 30-day mortality, myocardial infarction, and death/myocardial infarction as a composite endpoint were all higher for patients who received a red cell transfusion. As a result, some authorities advocate adopting a lower hemoglobin threshold of approximately 8 in such patients. So to summarize, a practical approach that might be taken in anemic patients with an acute coronary syndrome is that red cell transfusion should be addressed on a case-by-case basis in this patient population until data are generated from randomized controlled trials. Another patient population that requires clinical judgment includes those patients who have symptomatic anemia. Although there are limited data addressing this issue, in a few randomized controlled trials, symptoms of anemia were an indication for transfusion, regardless of whether the hemoglobin level was above the prescribed threshold for the hemoglobin trigger being evaluated. In general, it is reasonable to transfuse anemic patients with symptoms, provided that the symptoms are severe enough and are clearly related to the anemia rather than to another underlying process. Symptoms of anemia may include tachycardia unresponsive to fluid replacement, orthostatic hypotension, and those related to myocardial ischemia. It is also important to determine whether the symptoms have improved following the transfusion, because this information may guide future transfusion decisions. Although exertional symptoms, exercise intolerance, and fatigue may be helpful in alerting the clinician to the presence of anemia, such symptoms are generally considered too nonspecific to be an absolute indication for transfusion. However, again, clinical judgment is needed. The symptomatic anemia guideline is open-ended regarding an exact hemoglobin trigger for transfusion and states that transfusion should be especially considered when the patient has symptoms related to anemia and the hemoglobin is less than 8. However, some patients with significant symptoms related to anemia may be transfused at even higher hemoglobin levels in the range of 8 to 10. Some authorities suggest using a restrictive red blood cell strategy, such as a hemoglobin trigger of 7 to 8 in patients with congestive heart failure, unless other symptoms are also present, which might then warrant a higher hemoglobin transfusion threshold. When red cell transfusion is required in a patient with heart failure, careful attention to volume status is recommended, including adjustment of the transfusion rate and supplemental diuretics as needed to avoid volume overload. The next guideline addresses acute blood loss, including that occurring during general surgical procedures, and incorporates both hemoglobin levels and the estimated blood volume lost. The pace of the bleeding and the ability to stop the bleeding should also be used to guide transfusion decisions, as opposed to the hemoglobin level alone. The guidelines listed have been adapted from the British Committee for Standards in Hematology. Blood loss during cardiac surgery is addressed in a separate section of the guidelines and will not be discussed during this presentation. For patients who are massively bleeding or are hemodynamically unstable with blood loss on the order of 30 to 40% or more of the estimated blood volume, transfusion is generally indicated. In addition, bleeding patients with a hemoglobin level of 7 or lower are generally transfused. Red cell transfusion is also probably indicated when the hemoglobin level is less than or equal to 8 in patients with cardiovascular or pulmonary risk factors, similar to the practice guideline for non-surgical medical patients. Lesser degrees of acute blood loss on the order of 15 to 30% of the estimated blood volume are tolerated by most patients unless the blood loss is superimposed on significant pre-existing anemia, or when the patient has reduced cardiovascular reserve or continuing significant blood loss is anticipated. Red cell transfusion is not indicated when the loss of blood volume is less than 15%, unless the loss is superimposed on significant pre-existing anemia, or when the patient is unable to compensate for this degree of blood loss due to severe cardiac or respiratory disease. For patients who are bleeding and hemodynamically stable, some additional guidance is provided by a randomized controlled trial that was published in 2013 that suggested that a restrictive transfusion strategy was safe in the setting of acute upper GI bleeding when there was access to rapid endoscopic treatment and was associated with fewer complications, including a lower mortality rate. In this trial, a hemoglobin threshold of 7 was utilized for patients in the restrictive group. This study raises the possibility that in patients with bleeding from other sites who are hemodynamically stable, who are not at risk of complications from unstable coronary artery disease, and who have access to rapid surgical intervention, a restrictive transfusion strategy may be associated with better outcomes and also be safe. The next guideline addresses postoperative patients in whom transfusion should be considered for a hemoglobin less than or equal to 8, or for symptoms such as tachycardia unresponsive to fluids, EKG signs of myocardial ischemia, angina, congestive heart failure, or postural hypotension. The last guideline to be discussed deals with anemic patients who are receiving chemotherapy. The reference for this guideline is a 2012 practice parameter published by the National Comprehensive Cancer Network. And this guideline is more liberal, presumably because of the anticipated worsening of the anemia in patients who are being treated with cytotoxic drugs. Two patient groups not being discussed in this presentation include cardiac surgery patients and sickle cell disease patients. For those patient groups, I refer you to the guidelines that are published on PhysicianNet. So to summarize, some general statements that can be made with regard to hemoglobin transfusion triggers are listed on this slide. When the hemoglobin level is less than 6, transfusion is required, except in very rare circumstances. When the hemoglobin level is between 6 and 7, transfusion is likely to be indicated. When the hemoglobin level is in the range of 7 to 8, transfusion should be considered for some patient populations, such as those with stable cardiac disease, postoperative patients, and patients with clinically significant symptoms related to the anemia. When the hemoglobin level is between 8 and 10, transfusion is generally not indicated, but might be considered for some patient populations, such as those with significant ongoing blood loss, acute coronary syndromes, cancer patients on chemotherapy, and those with clinically significant symptoms related to the anemia. Finally, when the hemoglobin level is greater than 10, transfusion is generally not indicated. In summary, clinical judgment is essential regarding the decision to transfuse or not to transfuse. The decision to transfuse should incorporate the hemoglobin level and other individual patient characteristics, such as cardiovascular comorbid conditions and the presence of clinically significant symptoms. Also, in the absence of clinically significant acute hemorrhage, red cell transfusion should generally be administered as single units, followed by reevaluation of the patient's clinical status, the so-called transfuse and reassess strategy. And finally, data from randomized controlled trials have demonstrated that many hemodynamically stable patients who are non-bleeding and without high-risk cardiovascular comorbid conditions, including critically ill patients in the ICU setting, can safely tolerate a hemoglobin down to 7 without transfusion.